The background regarding carotid asymptomatic patients in carotid surgery. Asymptomatic patients with severe carotid stenosis, that is more than 60%, carry a 1% yearly risk of stroke. The peri-procedural risk of disabling stroke or death for carotid revascularization is also around 1%. Apart from this, non-disabling stroke is also seen, which is around 2 to 3%. Stroke risk is higher in carotid stenting, that will be shortened as CAS, whereas myocardial infarction is more commonly seen in carotid endarterectomy. Cranial nerve palsy is seen, which is exclusively seen in endarterectomy. Both procedures are more likely to have the above complications when it is done for symptomatic versus an asymptomatic stenosis. The incidence being twice as more frequently in symptomatic as compared to asymptomatic stenosis. So what is the trial data we have for carotid revascularization? In the 1990s, the NACET and the ECST studies were conducted. The NACET study showed that there was a definite benefit by doing endarterectomy for patients who are symptomatic with carotid stenosis, with the stenosis being more than or equal to 50%. And it was especially significant when the stenosis was 80 to 99%. The ECST study also showed us similarly that for patients with symptomatic stenosis more than 60%, it was a significant benefit by doing endarterectomy with a p-value less than 0.001. What about asymptomatic stenosis? So in the 2000s, the ACAS and the ACST trials, ACST1 trials were undertaken, which showed that endarterectomy is beneficial when done on asymptomatic patients with stenosis more than or equal to 60%. What it showed is that the yearly stroke risk by not doing any procedure was around 10 to 11%, whereas endarterectomy approximately halved this risk. However, at that time, the medical therapy available was not the what it is now. So anti-lipid therapy was not being given, and the patients were not taking that as well as they should be, or as they do nowadays. So these studies were done in earlier, and then the medical therapy was not as good as it is now. So currently, ESVS guidelines say that for asymptomatic stenosis, with more than 60%, patients should also have certain high-risk criteria, such as a large area of plaque or a large echolucent area in the plaque, or whether maybe microemboli may be demonstrated on various imaging methods. These are the high-risk criteria. If present, then patient is preferred to it's better if the patient undergoes a revascularization procedure. So now the procedure of choice. Endarterectomy was for the longest time the standard procedure that was being offered, and stenting also was being done for patients who were at higher risk of undergoing general anesthesia. So comparison between endarterectomy and stenting was done in the CREST-1 trial, which compared endarterectomy and carotid artery stenosis in both symptomatic as well as asymptomatic patients. And this trial had a total of around 2,500 patients studied, and the asymptomatic patients in each arm were around 600. It found that no difference was present in the primary endpoint between the two groups, which was the primary endpoints being stroke, myocardial infarction, and death in the 4 years of post-op follow-up. However, it found that there was a higher incidence of peri-procedural stroke in the stenting group and higher incidence of myocardial infarction in the endarterectomy group. The drawbacks of this trial is that there was a lower number of asymptomatic patients enrolled. So we needed a trial that evaluated asymptomatic patients undergoing stenting and compare them to endarterectomy on a large scale. So here we come to the second asymptomatic carotid surgery trial, that is the ACST2 trial. The PICO statement of this trial was that the population studied were asymptomatic carotid stenosis, with stenosis being more than or equal to 60%. The intervention being carotid artery stenting. The comparison was done to carotid endarterectomy, and the outcomes were peri-procedural risks, that is stroke or death, and long-term prevention of stroke was the other primary outcome that was studied. The trial design, it was an international multi-center single-blind RCT. 130 hospitals in Europe participated. Each hospital was required to have a vascular surgeon, an interventional radiologist. Sometimes the radiologist could be the same person. The vascular surgeon would develop as a radiologist. And it would also, each center would have a neurologist or a stroke doctor. And the collaborators were required to submit a review of their stroke outcomes prior to the procedure. That was, and they were required to have a peri-procedural stroke or death rate of less than 6% for symptomatic and less than 3% for asymptomatic patients to be eligible to participate in this trial. And ethics committee approval was done at individual centers as well as done by at the UK Coordination Center. The population studied, the inclusion criteria were patients with unilateral or bilateral severe carotid stenosis, that is more than or equal to 60% on Doppler ultrasound. Patients were required to have no symptoms in the preceding 6 months. There should have been CT or MR angiogram confirmation of suitability for the procedure. And both doctor and patient would have agreed on the need for procedure, but were uncertain on which procedure to opt for. And patients should have no circumstance or condition that is likely to preclude them from follow-up, and best medical therapy should already have been initiated prior to randomization. Exclusion criteria: if a patient with asymptomatic stenosis had a small likelihood of worthwhile benefit, that is, if they had a major comorbidity or a malignancy which was expected to shorten their lifespan and provide very low benefit, low likelihood of benefit. And if the patient was not suitable for either procedure, that is, if a tandem stenosis was present at the carotid siphon, precluding them from endarterectomy, or if there was complex vasculature proximal to the stenosis, precluding them from stenting. Randomization that was done was a 1:1 computer-generated minimization randomization. It was done by a randomization collaborator over the telephone, and the treating team would be sent a 6-digit trial ID and a randomization allocation. The intervention that was carried out, the procedure that was allocated would have to be done as soon as possible after randomization. Collaborators were not expected to deviate from their routine techniques. Peri-procedural dual antiplatelet therapy was usual, and for stenting, CE-approved devices were allowed, and there were no guidelines on embolic protection, and operators were allowed to stick to whatever they were comfortable with. Endarterectomy, for endarterectomy, patching and shunting were optional. Again, the operators were free to do what they usually do. And long-term medical therapy in terms of anti-lipid, anti-hypertensive, and anti-thrombotic therapy were similar in both groups. So post-operative care, in the immediate post-op period, a neurological evaluation was done by a neurologist or a stroke doctor. No tests were required other than usual post-op care. All post-operative events were documented. And prior to discharge, scheduling of the first month follow-up Doppler ultrasound and neurologist review was fixed. So at the follow-ups, there was a 1-month follow-up, which was a physical visit, and it was required even if the procedure other than allocated was carried out or no procedure was done. And at this visit, a Doppler, bilateral carotid Doppler, as well as a neurological evaluation was done in person. And following this, annual follow-ups, which was done by long-distance correspondence using a questionnaire, was done. So outcomes and endpoint classification. The primary outcomes were procedural mortality or morbidity within 30 days. That is procedural meaning within 30 days. And non-procedural stroke, that is strokes occurring more than 30 days post-procedure. And these were all divided by severity, subdivided by severity. And tools used for stroke measuring stroke were the modified ranking scale, in which a fatal stroke was classified as 6, moderate to severe was classified together as a moderate, that is 3 to 5, whereas mild stroke causing only slight disability were scores of 0 to 2. And myocardial infarction was diagnosed based on presence of 2 out of 3 criteria, that is those being symptoms, ECG changes, or elevated biomarkers. And statistical analysis was done using the SAS version 9.4 and R version 4.1 softwares. Separate subgroup analysis was done based on the initial allocation, that is intent to treat analysis, as well as based on the actual procedure done, that is sensitivity analysis. And Kaplan-Meier survival analysis was used to estimate the long-term outcomes. Results were also analyzed in conjunction with those from other trials, and that was summarized as a forest plot. So here are the results. a total of 3,625 patients were randomly allocated. 1,811 allocated to stenting, 1,814 allocated to endarterectomy. Of these, 1,578 underwent stenting, 1,668 underwent endarterectomy within 1 year. In each arm, there were crossovers to the opposite side. So 101 patients allocated to stenting had an endarterectomy, whereas 48 patients allocated to stenting had a crossover to, allocated to endarterectomy had a crossover to stenting. And around 106 did not undergo any procedure in the stenting arm, whereas 78 in the endarterectomy arm did not undergo any procedure. And the reasons for crossing over were usually anatomical requirements. Suppose patient under carotid angiogram showed a tortuous carotid artery, the patient was crossed over to endarterectomy. Whereas crossing over from endarterectomy to stenting arm was usually because of patient or physician preference, where if the patient did not want to undergo general anesthesia, or the physician decided that stenting would be preferable. And here is a figure showing that 88.5% of the stenting arm actually underwent stenting, and 2.8% of the patients who underwent stenting were from the endarterectomy arm. Similarly, in the 92.8% of the patients allocated to endarterectomy actually underwent endarterectomy, and 5.6% of the patients that were done, for whom endarterectomy were done, were from the stenting arm. And the general characteristics of the patients, we can see that in terms of sex, age, comorbidities, blood cholesterol levels, blood pressures, and degree of stenosis, both the groups were comparable. And this was just a few tables showing that the types of stents used, and that embolic protection was used for around 85% of the patients who underwent stenting. For 15%, no kind of embolic protection was used. And for patients who underwent endarterectomy, around 40% underwent had a patch repair, whereas the remaining approximately 60% did not have a patch. Shunt was used for around 25 to 30% of the patients, whereas no shunt was used for the remaining patients. And the antihypertensive lipid lowering therapy was similar in both arms. Almost all, around 93% of the patients undergoing stenting had dual antiplatelet therapy, whereas only 21% of the endarterectomy arm had dual antiplatelet therapy, but almost all the patients had at least one antiplatelet being given to them. So now we come to the results of the procedural events, that is, events that occurred within 30 days. These events were analyzed based on both on intention to treat, that is the initial allocation, which is seen on the left-hand side, as well as the actual procedure done, that is seen on the right-hand side of this table. What we can see here is that a similar number of fatal and disabling strokes were seen in each arm, and those numbers were not significant. However, the non-disabling strokes were 2.7% in the stenting arm and 1.6% in the endarterectomy arm, and this was a significant figure with a P of 0.03. But the subtotal of any stroke was again 3.6% in the stenting arm, 2.4% in the endarterectomy arm, which is not a significant value. Whereas for myocardial infarction, fatal MIs were seen only in the endarterectomy group. 4 patients died from MI in the post-procedure period. But if you see the subtotal of all MIs, endarterectomy patients, there were 12 MIs, whereas 5 were there in the stenting group. And this was not a significant difference. And if we compare death, MI, or any stroke, 3.9% was the incidence of events in the stenting, and 3.2% in the endarterectomy group, which was not significant. And if you consider only death and disabling stroke, again it was very similar, 0.9 and 1%, with a P of 0.77. Coming to non-procedural events, that is, events that occurred after 30 days, the results are very similar between the two arms. In stenting group, around the non-disabling strokes were 2.7 in the stenting group and 1.9% in the endarterectomy group. And the fatal and disabling strokes taken separately also were very similar. And overall, any non-procedural strokes, 5.2% in the stenting arm, 4.5% in the endarterectomy arm. We look at this Kaplan-Meier survival analysis. On the left side are the procedural events. So on top is shown the procedural death or any fatal or disabling stroke. In that, we see that the two procedures are very similar with a P of 0.86. The lower table on the left side shows the survival analysis of the procedural death or any stroke. So this includes the non-procedural strokes. And here we see there is a difference. There's a P of 0.09 in favor of the endarterectomy arm. And that shows that there was the difference in these two is made up by the non-disabling strokes in the procedural period. On the right-hand side, we see that there are the analysis of the non-procedural or disabling strokes on top. So it is very similar between the two arms. And when you see non-procedural stroke overall, there is a bottom right table. We can see that there is a slight advantage over to the endarterectomy, but it is not significant, and there is a P of 0.33 for this. So the results of this study were combined into a forest plot and compared to other other significant trials that occurred recently. So those included were the CREST trial, the SPACE 2 trial, and the ACT 1 trial. And in this, we can see that the trial being studied, ACST, is the one on top. That has the highest number of patients, 1,811 in each arm. So that has the lowest confidence interval and the highest effect size. Whereas the CREST trial, which is the next higher number, has 600 in each arm. That has a higher confidence interval and a lower effect size. And the SPACE and ACT2 trials also have lower effect size. But we can see that all these trials, all the confidence interval falls on the null effect line. And if we see the subtotal, that is the diamond seen at the bottom, that also falls on the null effect line, which shows that there is no significant benefit by either endarterectomy or stenting for asymptomatic patients. Here we have a separate subgroup analysis was done for to see whether any subgroup of patients would benefit by stenting or endarterectomy. Here subgrouping was done based on carotid diameter and then plaque echolucency and also by age and sex. But here also we see that all the confidence intervals fall on the null effect line. Hence, there was no subgroup that was seen to benefit by either endarterectomy or stenting. So what were the strengths of the study? The strength is that one, it was a large-scale study. It doubled the total number of asymptomatic patients studied when compiled with all the other trials that happened previously. And hence, we have a lot more data right now about asymptomatic patients. And it closely mimicked the real-world scenarios in terms of recruitment and treatment protocols. In that, there were all real dilemmas by physicians who did not know what procedure to opt for, and hence these patients were recruited for this trial. And it gave us some insight as to what to do with such patients. And it also allowed for physician and centers preferences with respect to procedures and procedural protocols. And the data closely resembled, when compared to national registries such as the German registry, the data closely resembled the incidence of procedural stroke and non-procedural stroke as compared to national registries in other countries. The limitations that the study had is that the sample size fell short of the original plan. They initially planned to recruit around 1,000 patients per year for 5 years. So since the sample size fell short, they had to compile this data into a forest plot along with other trials. Then it did not explore which treatment method, that is endarterectomy or stenting, would be preferred in whom. So the subgroup analysis did not arrive at a conclusion as to for which patient we would actually prefer to do which procedure. And it did not monitor the risk factor control during the follow-up period. It only told us as to what medication the patients were on. And the paper focused on the intention to treat analysis, and perhaps and there was no data given on the actual procedure done with respect to non-procedural strokes. So we don't actually know whether the procedure done, how much effect it actually had on the prevention of stroke. So the message we take home from the study is that current evidence does not show any significant differences in the procedural or long-term adverse outcomes in asymptomatic patients who are undergoing stenting or endarterectomy. And larger trials will be required to pick up differences, if any, on the long-term efficacy against stroke. Thank you. Sir?